Morning, everyone. Presenting on behalf of Medicine 2. For today's clinical meeting, it will be Mind You Gut. So, the history of a 60-year-old gentleman, a farmer from Chittor, has come with complaints of headache, mostly occipital headache, since 6th of April with vomiting for 4 days and vomiting mostly postprandial associated with nausea. And blurring of vision since the beginning of the headache. So apart from this, he also had a headache, vomiting, and blurring of vision. So, other than that, he also had loss of appetite 1 month prior to the presentation. But there was no other history of chest pain or palpitations or syncope, no seizures or no paucity of limbs. There was no abdominal pain or changes in the altered in bowel habits. There was no history of fever also. So for the past history, he's not a known diabetic or hypertensive. He's for the personal history, not a smoker or ethanol consumer. He has consumed Hans for 2 years. For the family history, his younger sister has died of oral cavity malignancy, who's known to be a tobacco user. So for the treatment history, because it's been a month of headache, but before presenting to us, he was evaluated outside. So for the first 10 days, he was managed with anti-inflammatory measures, and after that, since there was no resolution of his headache, CSF analysis was done on April 28th, which showed high WBCs with proteins mildly high and low glucose. He was treated as a case of meningitis for 14 days with meropenem and vancomycin, actually. With miro and vancomycin, and was also started on dexamethasone. Initially, he felt better after the initiation of dexamethasone for a few days. Again, he developed severe headache. Again, a repeat CSF was done, which showed increase in the total cells and very low glucose of 15. So for this, he has presented to us with recurring headache, and on examination, his vitals were stable. He was conscious, but he was drowsy but arousable. So he was oriented to time and person, not to place. Other general examination, there was no pallor, icterus, sinuses, or clubbing. There was multiple enlarged lymph nodes with about 1 to 5 centimeters from in level 2, 3, and 4. No axillary or inguinal nodes. There was no pedal edema. For the systemic examination, the rest of the systems were normal. His upper abdomen was soft. There was no tender. There was no organomegaly. No evidence of free fluid. Bowel sounds were normal. The CNS examination, he was not oriented to place. Other than that, he had no cranial no palsies. He had neck rigidity. He had neck stiffness was there. Fundus revealed no papilledema. Otherwise, his CNS examination was also, his tone was normal. His other signs were all normal. So for the clinical impression, he's a guy who was presented to us with primary CNS symptoms with headache, vomiting, and blurring of vision, with neck stiffness on present and cervical lymphadenopathy on examination. So, and 1 month history of loss of weight and loss of appetite also. So differentials, anyone? Okay. Anything else? Yes. Sure. So it's TB, chronic meningitis, or carcinomatous meningitis. Sure. So this clinical presentation, we also consider the same because of primary CNS symptoms with loss of height and loss of appetite with cervical lymphadenopathy. We also continue, and he was partially treated outside. So partially treated pyogenic meningitis versus a TB meningitis versus a fungal or any other primary CNS lesions. With
you said partially treated, he had 2 weeks of meropenem. Was meropenem in meningitic doses?
Yes, sir.
Why do you then say partially treated?
Still he is 2 days. Still he presented to us. The last one was we consider was carcinomatous meningitis. So initial investigations, his counts were normal. He had mild anemia with HB of 12. Platelets were normal. Creat was normal. Electrolytes were normal. His LFT showed mild hypoalbuminemia with 2.1 and proteins of 4.1. SGOT-PT was normal. So we did a CSF analysis which showed increase in the proteins, glucose of only 7 with the cell counts of WBC of 30, and we also had atypical cells present in our CSF. So when there is an atypical cells present, so if it is either it can be either a primary CNS malignancy or if it can be a disseminated spread. So imaging of the brain showed only leptomeningeal enhancement with no abnormal parenchymal enhancement. So only there is a leptomeningeal spread. So when there is a leptomeningeal spread, we'll have to work for so when there is a leptomeningeal spread, the CNS malignant, any other primaries causing a leptomeningeal spread, first initially we'll be thinking of a melanoma, or it can be a lung cancer, or it can be a breast cancer. So the further workup for the search of the primary, initially if it is only a leptomeningeal spread, primary thing we'll be thinking of is a hematological malignancies. Only if it is a solid malignancy, we can think of either a melanoma or a breast or a lung lesion. So peripheral blood smear did not show anything. Bone marrow done was normal. There was no signs of any hematological malignancies. There was a cervical lymph node biopsy which we biopsied that showed presence of metastatic adenocarcinoma. Otherwise, his markers, his PSA markers were normal. His CA19-9 and alpha fetoprotein were elevated. So, since we can also consider a primary malignancy from the lungs, we did a CT thorax, but it did not show anything, either for some probable infective etiology and some small subpleural nodules. Whereas then we went ahead with the CT abdomen, it showed multiple para-aortic, retrocaval and aortocaval nodes and asymmetric irregular thickening lesser curvature of the stomach with focal extraserosal fat involvement. So suspicion of a gastric primary. So usually this gastric primary causing leptomeningeal spread is very rare. So for a patient who was presented to us with primary CNS symptoms with atypical cells in the CSF, with leptomeningeal enhancement and with CNS, gastric markers being elevated and imaging showing probable gastric malignancy. A final diagnosis was carcinomatous meningitis, secondary to a probable gastric malignancy. So carcinomatous meningitis, it is usually more 80% it is with hematological malignancies, either a lymphoma or a leukemia. So how common is it with solid tumors? What primary solid malignancies to be suspected? What is the prognosis and management we are going to see? So epidemiology, solid tumors is only 5%. So undiagnosed carcinomatous meningitis, almost 20% are there with many solid tumors. So the most common type of, since breast cancer is more common than the cancers which is listed below, breast cancer has a higher distribution of leptomeningeal carcinomatosis, followed by lungs, followed by melanoma, and GI cancer is very rare. It's 4 to 14%, and when the number of case series published about GI cancer having a leptomeningeal carcinomatosis is very rare. But if we see the frequency, so the melanoma, they are given as 70 to 25%. So if in all these cancers, melanoma has 70 to 25%, it's reported. But if you see 100 melanoma patients, in that 46 will, almost 22 to 46 will have a leptomeningeal spread. So the frequency of the spread is more common with a melanoma or small cell lung cancer or a breast cancer. So the mechanism through which leptomeningeal spread occurs is either a hematogenous, most common it's a hematogenous spread, second is endoneural spread, can be a direct spread from the brain parenchyma. From the choroid plexus is very rare, the organ has to match to the choroid plexus and from there it has to get secreted into the CSF and from there we can get the atypical cells. De novo, like from a malignant peripheral nerve sheath tumors can cause a de novo tumors, or it can be iatrogenic during any neurosurgical intervention. So these are the signs and symptoms of the leptomeningeal, usually presents with all the CNS symptoms. It can be any cranial nerve palsies or how the patient presented to us with signs of meningitis. So this is one meta-analysis of all the case series who had initial manifestation as carcinomatous meningitis. So, but they had a primary GI malignancy. So far, 4 cases have been published, all presented with complaints of either headache or dizziness. One presented with bilateral hearing loss, one presented with cervical pain and headache, and one presented with CNS disturbances, facial palsy, and meningeal signs being positive. So these people, so 4 case series have been reported who had initial manifestation itself as like a meningitis, who had primary as GI cancer. Otherwise, there are other case reports which have been documented, patients who had a gastric cancer and then developed a carcinomatous meningitis. There has been reported. So this is one such journal where an 81-year-old female who was diagnosed with gastric cancer had a gastrectomy also post chemotherapy. 1 year she was okay. Then she came back with signs of meningitis, and in the CSF analysis it showed signet cells. So after that she was given. She did not survive. She was tried many treatments, but she did not survive. So it's a big therapeutic challenge when it comes to leptomeningeal carcinomatosis in GI cancer. There are many interventions tried with intrathecal methotrexate, with the normal systemic conventional therapy of docetaxel with oxaliplatin and 5-fluorouracil and cisplatin. But still the prognosis is not as good as the primary GI malignancy. If there is a leptomeningeal carcinomatosis, it's already stage 4B where it is only a palliative care. So for the diagnosis, CSF analysis shows a mild pleocytosis like we had, and elevated proteins as well as reduced glucose levels. Although these findings are not very specific, but there should be presence of atypical cells in the CSF cytology. Repeat CSF might also mean be warranted. So prognosis, overall survival in case of leptomeningeal carcinomatosis is very short, with median overall survival of 4 to 5 weeks without treatment and 2 to 4 months with treatment. So these are the options that are being tried now. So with the intrathecal chemotherapy also, the outcome is not very good. Apart from that, only radiation and palliation. So for our patient, we were not able to do a scopy because he deteriorated very fast after coming to us, and the family members were also not willing for the scopy because they wanted to take him home before he passes away. Radiotherapy and Monk we have consulted, but then they said he's not an ideal candidate for either of those. So only palliative care was offered to the patient.
Any questions from the audience?
The initial treatment.
Yes, sir.
You said it was in some other hospital.
Yes, sir.
Was there any workup regarding etiology, gram stain,
MG10 expert was done, sir.
culture? Nothing was done.
Cultures were negative, sir, and MG10 expert was done, which was also negative, sir.
And were the lymph nodes present at that time also?
Lymph nodes were there, but there was no biopsy attempted at that time. He had the lymph nodes, sir, but then they have not documented any lymphadenopathy.
What was the clinical feature of raised ICT here? You added something called raised ICT.
Yeah, continuously
The
here.
fundus was normal. Sometimes clarifying your history of vomiting might help in letting us know that if the patient has had a raised ICT. One more thing. See that statement that somebody who's got a stage 4B gastric cancer is only palliative care is probably because we don't understand what intent of therapy and what palliative care actually means. Stage 4B gastric cancer treatment is not just palliative care. It is systemic therapy with an intent is palliative. Doesn't mean that you don't treat them, and please don't use the word just palliation. Palliative care is very, very important, even if it's not involving any cytotoxic chemotherapy or radiation or anything. Please don't make such statements like this.
One comment about the audience response. See, the diagnosis is not TBM or carcinomatous meningitis. So this gentleman has a chronic meningitis.
Yes, sir.
There was no response to empiric antibacterial therapy, and he had extraneural involvement. He had palpably enlarged multiple cervical lymph nodes. So chronic meningitis with cervical lymphadenopathy. So then you think of the etiology.
Did we start antibiotics here on presentation?
First day itself, we had atypical cells, so we haven't started.
I think we had a similar case in the last 3 months also. We have presented one from M5, I think, leptomeningeal carcinomatosis, again with an adenocarcinoma. Thank you. Thank you.
Is it primary?
I think it was gastric.